Welcome to the Brain People Podcast, a show where four mental health experts team up to bring you practical tools for overcoming mental health challenges. The Brain People don't replace your doctor or therapist, but we will give you some extra tools to help you on your journey. So join us as we fight mental illness, one episode at a time.
Welcome to the Brain People Podcast. My name is Jonathan Edens. I am your host today, and with me I have my co-host.
I'm Dr. Daniel Binus, and I'm a psychiatrist.
And I guess I should mention my credentials too. I'm a psychiatric PA. For those that have been listening to us for a while, we are regulars on this podcast. Today we have an important topic. We'll be discussing bipolar disorder. For longtime listeners of this podcast, they may know that we've actually done a previous episode on bipolar disorder. And so today is going to be a little bit of a different episode. Today, what specifically are we going to be talking about as it relates to bipolar disorder, Dr. Binus?
Well, we're going to be honing in on treatments, evidence-based treatments for bipolar disorder.
And one thing I do want to mention about why we have chosen to do this follow-up episode on bipolar disorder, specifically as it relates to the treatments for it, is actually somewhat user or listener, a response to listener comments that we got on that first episode. It's actually our most, at this time, it's our most viewed YouTube video. And some of the comments in the YouTube video for that previous episode, which I believe was episode number 3. I believe it was episode number 3. And some people felt like we were basically telling them that medication was not appropriate, that they should get off of medication, that they could do it without medication, that they could basically use some of the alternative therapies like cold water immersion and dark light therapy and things of that nature in order to manage manic episodes. And so we wanted to have this follow-up episode because we understood why some people may have been confused or may have gotten that impression, and we wanted to clarify our position and talk about, have a more thorough discussion on the treatment options for bipolar disorder. That episode was primarily just a discussion of what is bipolar disorder and so on. Any comments about that, Dr. Binus?
Yeah, I think it's important that people understand that we try to have a very balanced approach when it comes to mental health. And I think our thrust in that episode was really to help our listeners to understand that there are more things that can be done than just medications. But I think maybe the confusion and the thing that we didn't emphasize is that we are not anti-medication, and we do believe that there is a significant and important role for medication in the treatment, the management of bipolar disorder. That being said, again, it doesn't negate the importance of the holistic interventions. And I've just seen phenomenal results in people's lives when they are willing to really combine the best of both worlds. And really, I think that's what we want to talk about today.
Yeah, the push that we've tried to have with this podcast is one that is not so much like against the narrative that tends to come along with this psychiatric field in general, but more so to say that there's this right, that there may be some additional things that you could do in conjunction, but ultimately what we're about is what works best for you, right? And so for many people that may be a solely traditional sort of psychiatric approach, and for many people that may include some of these additional kind of adjunctive type therapies that may be less talked about. And so we're hoping to broaden the discussion to help make you aware of some alternative treatments that are available that have maybe some evidence backing, and they may be something for you to consider under the supervision of your own mental health provider. And so this is a perfect sort of segue into medical disclaimer, right? We are not for majority of our listeners, we are not your medical providers. And so this podcast is for informational purposes only, and you should not be using this information to make decisions about your own medical situation, your own treatment plans. You should be discussing all things with your own personal medical practitioner. So with that being said, let's go ahead and jump right into it, Dr. Binus. Um, uh, Anything you want to say just kind of about bipolar disorder before we go ahead and jump into treatments?
Yeah, I mean, I think one thing I will mention is a lot of people that think about bipolar, and you get the terms like manic kind of thrown around a lot and that sort of thing, and stop being so manic and this sort of thing. To really meet the definition and criteria for bipolar disorder, it is a distinct period that lasts for several days of a change in mood. Now, it can be either a mixed state or a manic sort of euphoric state. But this is not something that just happens for a few hours or maybe even a day for that matter. It's something that goes on for several days. And I think that's really important to emphasize that it's a distinctly different change in someone's baseline mood. And again, typically going to involve greater energy, disrupted sleep, oftentimes either euphoria, irritability, agitation, and then impulsivity, this sort of thing. And then, and it can last for, from several days up to months at a time. And a lot of people, again, I think confuse mood swings with bipolar. Mood swings are not the same thing as bipolar. And so it's important to really tease that out and not try to self-diagnose like, oh, I must have bipolar if I have mood swings. You need to get, someone that really knows what they're doing. Even a lot of mental health professionals struggle to make a clear diagnosis sometimes. And it's not always the fault of the mental health professional, because sometimes the information gathering can be difficult and all of that. So this is not always a clear-cut diagnosis. But again, when we're talking about bipolar, and the treatment of bipolar, we're talking about clear-cut diagnoses of bipolar where someone really is struggling with that illness.
And one thing I'll add is oftentimes the interpretation of events, seeing through the person with the manic episodes themselves, are not going to be the most accurate. And so getting that family involvement, right, getting somebody that is really familiar with your situation, such as a spouse or maybe even a child or a parent or a close friend, right, can be really oftentimes extremely valuable information for your provider if you are unsure about the diagnosis and with that, which treatments you should pursue. So why don't we segue into a conversation about medications and which medications are indicated for bipolar disorder, and we'll talk about some of the nuance with certain meds, kind of the unique benefits that they may have, some of the unique downsides, and also how they may how they may affect the manic phase versus the depressed phase, and so on and so forth.
Yeah, well, you can't start talking about pharmacological or medication interventions for bipolar without actually talking about lithium first. I mean, that was the first one that really was used for bipolar when it comes to medication in 1970. And in a lot of ways, it's still the gold standard for bipolar treatment. And lithium's an interesting thing because it's actually a naturally occurring element. And our bodies utilize lithium. It actually is often found in drinking water. Interestingly enough, lithium does have anti-suicidal properties. And they've even seen this where they've measured lithium levels in drinking water and found that areas that have naturally higher occurring levels of lithium in the drinking water, those regions tend to have lower suicidal rates. And so it's pretty fascinating.
And crime, right? Lower rates of aggression, particularly violent crime. I should say.
Yeah. So it is actually very interesting because what we see is that it reduces that excitatory, like dopamine and glutamate, but at the same time increases the calming effect of GABA in the brain. And so this is why lithium really does help to kind of stabilize neuronal function. And an aspect of that is that we actually see neuroprotection with lithium. And what that means is there's some studies that show that it helps to induce positive neuroplasticity or positive brain changes, and even increases the volume of brain matter. And part of that seems to be, of course, because of the it helps not you not to have that over excitation in the brain. But another aspect is that it does seem to actually increase BDNF, brain derived neurotrophic factor, which is kind of like brain fertilizer. And so there's parts of the brain, particularly that help to regulate the emotional response, like the prefrontal cortex and other parts of the brain that are enhanced, or they enlarge with lithium treatment. So there's actually quite a lot of upsides to lithium. And the other piece is it tends to work really well. And I will say, in my experience, and is some research that points to this as well, particularly it works well with euphoric mania, the classic type of bipolar mania. It doesn't tend to work as well with the dysphoric mania or the mixed states that we sometimes see. But the classic, like euphoria, elevated mood, those sort of manic disorders, people tend to do quite well with lithium.
Real quick, Dr. Binus, can you just define what a mixed state is?
So a mixed state would really be related to when someone has mixtures of both depression and mania in the same episode. And so with that, someone could be having a level of agitation and depression at times, but then also feeling highly energetic and agitated and impulsive and that sort of thing. And so it can be a very, very uncomfortable state for people.
One thing I do want to emphasize, where you talk about the neuroprotective benefits of lithium specifically, part of why this is so important is because of the damaging effects that mania and depression have on the brain, right? And so something that is neuroprotective in and of itself is extremely vital if you're not, if you already have, say, maybe damage structurally, right, neurochemically to your brain because of multiple episodes. Yes, you can reduce further damage by preventing future episodes, right? But there may be almost like a post sort of soothing or post healing effect by taking lithium as well. So it's very interesting and unique in that particular sense as well.
Yes, yeah, and of course, lithium also has its downsides, right? And that's what.
Sure.
So again, lithium can be very helpful, but the reason we don't just give lithium to everybody, because so far we've talked about there were quite a few upsides, is because there can be significant downsides. The ones I see most commonly that people complain of is, for a lot of people, it can cause some significant sedation, especially at the doses that you need to really treat bipolar disorder, which tend to be a little on the higher side for most people. And so sedation, weight gain, and then also the long-term effects. I mean, some people are on lithium for 20, 30 years and they do okay. And then suddenly they go to their annual checkup and they see their kidney numbers have skyrocketed. And that can be a real problem because literally for some people, long-term taking lithium, and some people that are more just more prone to it might even happen in a shorter duration of time, but kidney failure can be a big issue. Another factor is that it can affect the thyroid. Now, that's not as concerning in my mind because, with the thyroid, we can typically give some thyroid medication, and that can improve the overall symptoms. But the kidneys, that's a big deal. I mean, you don't want to go into dialysis or get a kidney transplant, right? And so that's the most important thing to consider when you're talking about going on lithium.
Yes, people that have kidney issues already, right, that can be an issue when it comes to being on lithium. But in my mind, another consideration is somebody that's going to need treatment likely indefinitely, and maybe they're relatively young. I know that there's a likelihood that if they are on lithium for a very long term, it's often somewhat of a guarantee, right, that they're going to have kidney damage later on. And so for those reasons alone, I think a large swath of the psychiatric industry has kind of shied away from using lithium as a first line agent, right?
Yeah. Now, I will say this. I have had some people on lithium where their kidney function was actually going down. And then through being, well, it was kind of a combination where we looked carefully what's the lowest amount of lithium that we can get away with and still keep the mood stable. But then lifestyle interventions, interestingly enough, I've seen some people where their kidney function actually improved while they were still on lithium. And that was pretty phenomenal to me. And so, really being careful with their amount of protein consumption, switching to a plant-based diet for many individuals can help on some levels, eliminating certain drinks, like especially dark colas and any even dark teas and whatnot, staying away from NSAIDs, limiting caffeine, staying well hydrated. All of those things can enhance the longevity of the kidneys and make it easier to tolerate lithium. One other thing I should mention though about lithium is that you can get toxic pretty quick. And so you got to be extremely careful as far as the monitoring goes, and making sure that you're not getting dehydrated. Because if you get dehydrated when you're on lithium, ooh, that can really make your levels go up rapidly, and you can get confused, and you can get even go into a potential coma. Seizures, et cetera. And so you got to be really careful as far as the dosage range when it comes to lithium.
Yeah, and you mentioned NSAIDs, right? So over-the-counter anti-inflammatory medications. That's classically known to change the way your body processes lithium. You also mentioned dehydration, but salt, right, also can be another key player there, right? You go to a sushi buffet and you just overload yourself with soy sauce while you're on lithium. That could be a little bit of a problem. So, right, there's oftentimes we do a little psychoeducation. I should say pharmacological education regarding lithium, particularly regarding these things. So these are just important factors to know if that's something that you're considering. All right, let's talk about mood stabilizers, Dr. Binus. So generally, this is sort of the big umbrella of medications. Obviously, as the name implies, these medications stabilize mood. Shocking revelation, I realize. But the two classes of meds underneath that would be the anticonvulsants and then the antipsychotic medications. So why those two classes, Dr. Binus? What sort of medications are under those classes? Go ahead and break it down for us.
Yeah. So basically, when we think about bipolar, it is a very complex disorder. And so certain medications are going to work well for certain individuals and other ones just won't. And some, people have a milder level of illness. Some people are more prone to rapid cycling. Some people are more prone to mixed episodes. So we need quite a variety of different medications to treat different symptoms. And when we talk about the mood stabilizers, anticonvulsants particularly, we're talking about anti-seizure medications. And why do those work? Well, if you think about someone when they're having a seizure, what are we talking about? We're talking about a group of nerve cells that is firing when they're not supposed to. And so when we think about bipolar, especially on the manic side, right, you're getting nerve cells that are firing too much. And so the anti-seizure drugs actually tone down that overfiring. And then on the depressive side, the mood stabilizers don't always work as well. But there is, some help at times. And again, you might have parts of the brain that are actually overactive, even with depression, with the, the negativity, the rumination, the anxiety that can come on with the dysphoria. Although again, by themselves, none of the mood stabilizers, and when I'm talking about mood stabilizers right now, I'm talking about anticonvulsants, none of the mood stabilizers by themselves have an FDA indication for bipolar depression, okay? Now, that being said, they often do help on some levels. And so we're talking about Lamictal, lamotrigine is the other name for that. This is one of my favorite medications to use with bipolar. And the reason being, the side effect profile is actually pretty good. The downside is that it tends to not be so great with the more pronounced bipolars, the ones that like the bipolar type 1, the more severe bipolars. So the milder bipolars, the bipolar type 2, maybe the milder bipolar type 1s, the ones that are a little more prone to the depressive side of things. This is where the Lamictal can often be very helpful. And I have seen, even though, again, it's not FDA indicated for depression, it does tend to have pretty good antidepressant effects for a lot of people, and it has some nice mood stabilizing effects. It takes a long time to get to an effective dose of Lamictal. And that's one of the most frustrating things, I think, for a lot of us as clinicians, because if you titrate the dose too quickly, you can get a skin rash. And typically, you'll get itching in the rash, and that can turn into something very dangerous, which is called Stevens-Johnson, where you actually start getting your skin peeling off, and that can lead to secondary terrible infections and potentially even death. So, but I always tell people, I know this sounds horribly scary, and why would you even try something like this? But the likelihood of that happening is extremely low if you know what to look out for. And if you start having that rash and that itching, or the itching, I should say, then and you take measures right away. In other words, stop the medication, take some kind of antihistamine, that can be generally easily reversed. I've had a lot of people, it's still not many, comparison, but I've had several people, I should say, get the rash, and we address it properly, and then we move on from there. No harm is done long term. So it's still a very good option, I think, for people. And another one that we often consider is Depakote, valproic acid. This does have is highly effective for mood stabilization, especially when someone is manic or mixed state. And actually, it's very helpful for what we call rapid cycling, where people are going in and out of episodes rapidly. So when we're talking about someone that has frequent episodes of mania or mixed states, then a medication like Depakote, or the next one we're going to talk about, Tegretol, which is carbamazepine, those tend to be a lot more helpful than Lithium, and Lamictal is usually not very helpful in those situations either. But Depakote's quite useful for agitation. Problem is, weight gain, hair loss, and then you really got to watch this one, especially as far as fetal birth defects are concerned. Carbamazepine, used less frequently due to many drug-drug interactions, but can also be very helpful in mood stabilization. Now, there is a medication that's similar to Tegretol or carbamazepine called Trileptal, and that one tends to have less of the medication interactions. And so that one I do sometimes use as a mood stabilizer. And that one tends to work pretty well, especially for more of a bipolar type 2.
Any other anticonvulsants, or should we move on to antipsychotic meds?
No, I think for the most part that those are the highlights. There's always more that we could talk about, but we don't want to, most of our audience is probably not super interested in every little detail.
Yeah, one thing I would add that is fairly commonly, or I should say it's becoming increasingly commonly used, is gabapentin. So, it's another anticonvulsant often used for pain management, right? Because so many people are taking narcotics and their providers are trying to get them off of them. And so they're switching them over to something like gabapentin. One thing we do want to say is, gabapentin is not indicated for bipolar disorder, even though it is becoming more frequently used. So there may be some utility in some situations, but there's some pretty significant risks with gabapentin as well. So if that's something that is in your options list or in your wheelhouse per se, definitely worth discussing with your provider. Moving on to antipsychotic medications, right? They're called antipsychotics because they reduce psychosis, but there's a lot of overlap with mania in terms of their dopamine blocking ability to reduce mania and also reduce psychosis, right? So that's why they're called antipsychotics. We're not saying because you have bipolar disorder and you're taking an antipsychotic, you are psychotic. Just wanted to make that clear. With that being said, there are three. We always really break it down into two generations. More often, we're considering there to be a third generation of what we call partial agonists. Can you tell us a little bit about those different, what the medications in those different classes and what distinguishes them from one another?
Yeah, so the first generation are basically the first antipsychotics that came out, and so that'd be like thorazine, which is chlorpromazine, and Haldol. Those are the ones that tend to work very rapidly. They're kind of the heavy hitters, if you will. Most of these tend to block dopamine receptors pretty strongly and have a rapid response with stabilizing the mood. And then if there is psychosis present, because there can be certainly with bipolar episodes, although it's not always the case, they tend to respond pretty rapidly to that. But the problem is that you run into a relatively high risk of what we call extrapyramidal side effects. So that can include things like acute dystonia, where you have like your muscles like binding up and contracting. It also can lead to Parkinsonism. So where you have basically can develop a tremor, you can have a lot of rigidity, and you can get even things like postural hypotension and that sort of thing. So and then long term, and it can happen with any antipsychotics, but tends to happen even more with the first generation ones. You can develop tardive dyskinesia, which are abnormal movements late in the course of treatment, which are just basically automatic movements. So that is concerning, obviously. And then, not to mention, any of the antipsychotics can cause what we call metabolic side effects, including elevated blood sugar, cholesterol, and weight gain. So because of the higher potential for side effects, the first generation we tend to be careful with. Again, we utilize them at times, especially if maybe some of the second generation medications aren't working as well. But we want to just be very cognizant of those side effects.
Anything else you want to mention about the antipsychotic class?
Well, I definitely, yeah. The second generation and third generation. So with the second generation, those would be medications like Zyprexa, which is olanzapine, Seroquel, quetiapine, Risperdal, ziprasidone, and azenapine, which is Saffris. So these ones tend to be rapidly effective for mania, for agitation, and they do have lower risk of those extrapyramidal side effects. But again, higher risk of those metabolic issues that I was mentioning earlier, as far as the cholesterol, blood sugar, et cetera. And one thing I will say is that in my experience treating acute mania, I lean towards olanzapine, just because it tends to help both with sleep, because it's pretty sedating, as well as it has really good antipsychotic capacity and mood stabilizing ability. And so that tends to work really rapidly and nicely for a lot of people. And then the third generation includes aripiprazole, which is Abilify, and then Latuda, and you could argue whether Latuda maybe is more second generation or third generation. Also Vraylar, and then Caplyta. And so those tend to be more effective for bipolar depression. And the nice thing about these is there's lower risk of both the extrapyramidal side effects and also lower risk of the metabolic issues like the cholesterol and weight gain, although they still can have them. And so we can't ignore those issues. And again, not as good for the acute episodes of mania, but better for the depressive episode. And actually, when we look at the FDA-approved medications for bipolar depression, there's not a lot of them. And I should probably pause here and just say that when we think about bipolar depression, sometimes with bipolar, we really focus on the treatment of the acute manic episode. And
Yeah.
that's very important. But when you think about the disability that comes from bipolar, the majority of it is related to the time that people spend in depression. And people with bipolar disorder experience full-on depression on average about 19% of the time, even for people that have been treated, that are being treated. And then another 18% of the time, they have subsyndromal depression. And so, what we're looking at is almost 40% of the time, people with bipolar disorder tend to have those depressive symptoms. And that's in pretty clear contrast when you think about only about 10% of the time people are in hypomania, and then maybe only about 1% of the time in mania. And so again, it's important for us to really look at when we're treating bipolar, not just trying to prevent manic episodes, but also what can we do to help the depressive phase. And so again, this full circle, bringing this back around, we need to think about like what options do we have? And unfortunately, FDA approved, we don't have a ton of options. There are some options that often work well, and I'll mention those. Most of those are basically the antipsychotics. One, interestingly enough, is a combination. It was approved in 2003. It was the first one that was actually officially approved, which is a combination of olanzapine, which is Zyprexa, plus Prozac, fluoxetine. And so that one is FDA approved. It's a combination pill, Symbyax. But most doctors nowadays probably just dose them separately. The other one that was approved next was Seroquel, quetiapine. And then Latuda was approved, then Vraylar, and finally, most recently, Caplyta. And so all of those are FDA approved for bipolar depression and can often be very helpful. But again, by themselves are not always the solution for many people, which can be very frustrating for both the patient and the clinician.
So what about antidepressants, Dr. Binus? Why are we not talking about that for bipolar depression?
Well, that's a great question. And interestingly, like we said, the first one that was FDA approved was actually a combination of Zyprexa plus an antidepressant. But there's a lot of discussion, a lot of debate, even to this day, about utilizing antidepressants when it comes to bipolar depression, because the concern is, and has always been, could these antidepressants switch somebody into mania? And the answer is yes, sometimes they can, but the rate that happens is usually not it's not very high. It's generally thought to be less than 5% when we're talking about SSRIs, especially if someone's on a mood stabilizing medication. Now, for the older antidepressants, the TCAs, that rate of switch into mania is probably higher. According to the data, they tend to be a little more potent, just at kind of tripping people into those manic episodes. So it's off label, but it happens all the time in psychiatry, in mental health, because when you're not getting traction and you're horribly depressed, or you're on the other side of the couch and you're the psychiatrist and you're looking at your patient, you're being like, what can I do to help this person? Then you start exploring options. And I have seen people that have clearly bipolar benefit at times from antidepressant therapy, but that needs to be done extremely cautiously. It needs to be done, obviously under the guidance of a very experienced psychopharmacologist, and also needs to be done in the context of being on a mood stabilizer that is potent enough to keep someone from that manic switch. And so there's caveats. And again, I don't think we're ever going to see FDA approval for that, because it's so anecdotal, but it does work for some people.
Yeah. I think I saw one. It was the results of a survey, basically, and they essentially found that like roughly 10% of psychiatrists said they would never use an antidepressant in somebody with bipolar, and about 10% said they're completely comfortable with using an antidepressant without a mood stabilizer. And so the remaining, 80% said, yeah, like we're fine with using an antidepressant if there is an effective mood stabilizer in conjunction. And within the last few years, we've got a number of new medications that have been helpful, more helpful, I should say, for bipolar depression. And I've gotten that indication. So before there was a lot of this adding antidepressants because that was one of the only treatments that we had, especially for those that maybe couldn't afford the more expensive newer medications with that indication. And so it's been a part of the industry for a while. And so that being said, I wanted to just briefly mention like polypharmacy, which is often used in sort of a negative connotation, is kind of, I hate to say this, but like it's very standard practice when it comes to bipolar disorder because as is the nature of the illness is that you have two very distinct, some quite opposite phases, right? That have very different neurochemical changes, right? They're very different from one another. And so coming up with a molecule that can have a beneficial effect on states that are completely different from each other is very, very challenging to do, right? And so that's why so many of these medications are only good at one state. Either the manic phase or the antidepressant phase. And so it's quite unique when a medication can kind of do both. And really, like, did you want to mention that the medication that technically does have the indication?
Oh, the indication for both. Yeah,
Yeah.
Seroquel actually does have the indication for both. So
So does
quetiapine.
Vraylar, right? So we've got really only two medications that can treat both mania and bipolar depression, and so it's quite it's quite unique to have that. Now we're not necessarily saying that these are the best medications, right? We're just saying that it's quite a unique feat that they were able to accomplish that.
Yes, exactly. Yeah, well, and so maybe we can move on beyond meds. I think that's a good overview, and hopefully everyone now understands that we're not anti medication. Although, again, we just believe so firmly that when you add these other things that we're about to talk about here, it really allows individuals to decrease the use, the overuse, maybe I would say, of medications, minimize the use so that the quality of life and the likelihood of developing significant side effects becomes a lot less. And so that's why we really believe like, okay, meds are very helpful and generally needed with bipolar, but there's so much more that can be done to really enhance the quality of life.
So what first sort of adjunctive or complementary treatment did you want to discuss?
Well, I'd like to get into the psychotherapy and just do a brief overview of that because, I think that there's a lot to be said. Again, sometimes we think of bipolar as such a biological illness that, you don't really need psychotherapy for that. But there are several evidence-based strategies when it comes to therapy for bipolar that is helpful for outcome. And so some of them are as simple as psychoeducation, just basically helping people to understand the importance to seek and adhere and continue treatment. And that really, and also just being aware of what the triggers are and the symptoms to look out for and when to get help and who maybe is the go-to person in your life that you're willing to listen to, hopefully, when things are getting kind of unstable. So all those things, just simple psychoeducation and really taking that seriously can be helpful.
One thing I'll touch on that it's often as important to educate the spouse, the parent, the child or whatnot, as it is to educate the patient, right? Because oftentimes when somebody's in the midst of a manic episode, you're not getting the call from the patient, right? You're getting the call from a concerned family member, and so in my practice, it's been fairly standard to make sure that not only can the patient, but whoever is going to be sort of overseeing their care, if something like that were to happen, that they have an easy way of getting in contact with me.
That's right. Yeah, and that actually dovetails into another type of psychotherapy that's called family-focused therapy, and it's clear from data that unsupportive and negative family or interactions with family really do increase a patient's stress and vulnerability to more depression or other even manic episodes at times. And so it's important to make sure the family dynamics are helpful and supportive rather than in any way detrimental to the individual. So, another type of therapy, which is pretty classic for most psychiatric disorders, cognitive behavioral therapy. And with cognitive behavioral therapy, basically, we're teaching people to challenge their beliefs and their thoughts and even their behavior. And basically, by optimizing your thinking patterns, your beliefs, your behaviors, this really does influence your emotional state, and it can either make you feel more stable and have a better mood and a more positive mood, or really, if your thoughts and your behaviors and your beliefs are off, that can really be a trigger for people.
So are you suggesting that say stress or kind of fixed false maybe emotionally dysregulating beliefs can actually trigger depression or manic episodes?
Oh yeah, absolutely. I mean, I see it all the time in my patients with bipolar, where they're doing okay, and then they have some kind of major stressor happen in their life, and it really can push them over the edge into either a depressive state or into a mixed state or a manic state, and so it's really important to understand, how to regulate your thoughts, your behaviors, your emotions when you're faced with something difficult. Another one that I think is very, very important when it comes to psychotherapy, which we could almost put it under psychoeducation in a way, but there's a different category. It's called interpersonal and social rhythm therapy. So essentially, here, the idea is really helping people to develop a very regulated circadian rhythm. In other words, a schedule. And one of the things that I often see is when people have disrupted daily routines, this in turn leads to circadian rhythm instability, and then that can worsen either depressive episodes or even trigger mania. And so it's really important for people to have regular times for eating and sleeping. Those are kind of the anchor points I tell people. Every day you got to take your meds at the same time, you got to eat at the same time, you got to sleep at the same time. And it's not just sleep at the same time, but ideally, you want to get some sleep before midnight, sleep while it's dark outside. That's going to be the most effective, helpful sleep. And then that will help to actually stabilize the mood.
And if you want more information on that, we do have an episode on insomnia, so you can go back and listen to that episode.
Yes. And then the final psychotherapy that I'll mention for now, unless you had one you want to add in, is it's not even a real psychotherapy, it's just peer support. And so having peer support groups, having that support from other individuals that are struggling with the bipolar as well can be very helpful, realizing you're not alone, realizing that there's hope for recovery, and it really reduces the stigma, helps with that sense of connectedness, which is super important, because a lot of times when you're dealing with a disorder like bipolar, it can feel very lonely, like, oh, there's something wrong with me, I'm just way off here compared to everybody else. But it's important to realize that there's a lot of people that struggle with bipolar, and there's other people that have learned secrets and are doing well, and that you also through the right medications and the right type of support and the right lifestyle interventions, things can get better.
Yeah, one psychotherapy that I would add is dialectical behavioral therapy. Now, dialectical behavioral therapy includes things like mindfulness, interpersonal effectiveness, distress tolerance, and emotional regulation. And for those that are familiar with DBT or dialectical behavioral therapy, they might think, oh, well, that's for those with borderline personality disorder. Oftentimes people with bipolar or diagnosed with BPD and vice versa. There are some people that do have both. But that being said, just like CBT can be helpful for bipolar and a whole host of mental health conditions, so can dialectical behavioral therapy. It's sort of a unique flavor of cognitive behavioral therapy that emphasizes those things that I just previously mentioned. And so it also generally, if done correctly, comes with a group component as well. And I think that in conjunction with the individual psychotherapy can be really helpful for those with bipolar disorder that tend to have a lot of emotional dysregulation.
Yeah, no, that's a good point. And like you said, Jonathan, it really is almost kind of like a subtype, if you will, of cognitive behavioral therapy, but it can be really helpful for individuals, especially if they're struggling with that emotional dysregulation.
Any other treatments you want to mention?
Oh, yes. These are, the really exciting ones for me. So, like most of our podcasts, so especially the ones that are more treatment related, we can't ignore the importance of exercise. And especially for bipolar depression, there really seems to be significant data that's starting to be shown. This is early trials, but still, exercise is just great, overall. But one study that was done just in 2023, granted, it was a small study, but really robust effect. This is 15 patients diagnosed with bipolar type 1 or 2 in a depressive episode. And basically what they did is they exercised 3 times per week, and they did it for 12 weeks, so it was quite long, 36 training sessions. But what they found at the end of the training sessions is that 82% had antidepressant response defined as a reduction of more than 50% of depressive symptoms at week 12. And then 5 of those patients presented actually with criteria for full remission. And so I thought that was really neat that just exercise by itself, again, just a simple study, only 15 patients, but it just shows that it can be truly helpful. The problem with bipolar depression is that a lot of people are so unmotivated to get them to do that. But again, that's why the strength of the study, I think, was that structured intervention. And I think if we can do more structured interventions to help people exercise when they're depressed, whether it's major depression or bipolar depression, we could get a lot of traction, with really helping them to get out of that depression.
And anything else about exercise, or?
No, let's move on. There's another one that I got pretty excited about too, and this is on light. So light therapy is also showing great promise. And again, this doesn't mean that we just abandon our medications or whatever, but pretty exciting that this study was a 6-week randomized, double-blind, placebo-controlled trial, and it looked at adjunctive bright light therapy at midday for bipolar depression. And so basically, they were randomized to either 7,000 lux bright white light or 50 lux dim red placebo light. And obviously, they could tell the difference between the red and white, but still, it was a placebo-controlled, right? Because they didn't know which one was supposed to help the depression. And what they found is that the people in the bright white light group had a remission rate of about 68% compared to only 22% of the ones in the other group. And that to me, again, is very encouraging, because if you think about the exercise, you think about the light therapy, very low likelihood of side effects, right? Especially when you think about the exercise, there's generally only good side effects, and pretty robust response rates that we're seeing there. Now, with the light, you do have to watch out. You could potentially get into that manic switch if you're not careful, but some pretty exciting results.
Yeah, I definitely say so. And to an extent, the opposite can be true for someone with mania, right? Like if you're a patient that's
Yes.
in, say, hypomania, maybe you're not necessarily severe enough to need to go to the hospital, then you can have maybe your spouse or whatnot incentivize you, try to keep you inside, keep you in a dark room, even during the daytime, right? And that can definitely help to shorten the duration of the manic episode
Yeah,
as well.
there was even one study where they were looking at dark exposure, basically when people are manic, and they've looked at there's a couple studies that have been done on that where people are spend more time in the dark, and that can tend to tone down the hyperactive, agitated, or manic state. Sometimes it seems like even wearing blue blocking glasses
Yeah.
can be helpful for that as well. So moving on to some more emerging treatment options, especially when we think about um, bipolar depression, because again, bipolar depression can be one of the most difficult and debilitating parts of the illness and difficult to treat. So there are other options that are being explored, and I just want to mention those briefly because I think it's helpful to kind of be aware of those and then see where the data goes as far as FDA approval and that sort of thing. So one that I think is very interesting is transcranial magnetic stimulation. This is where there's an MRI strength magnet that creates an electromagnetic field and stimulates, generally speaking, the left frontal lobe to help produce an antidepressant response. Definitely FDA approved for major depression, and it's close. There's some studies that are showing some real some help that TMS can actually give to bipolar depression as well. So that is promising for many people. Another one that is being explored, not FDA approved, but ketamine, and some people seem to do well with bipolar depression for that as well. One that I was not so familiar with, but I thought was very interesting, is vagal nerve stimulation, and that's been FDA approved for treatment-resistant unipolar depression, just regular major depression. But there was a 5-year prospective study where 63% of patients with treatment-resistant bipolar depression treated with adjunctive vagal nerve stimulation had significant reduction in depressive symptoms. And so they had a response, which I thought was pretty profound because, again, these were people that were treatment resistant. So I thought that was very interesting. And then, there's some other off-label things that are sometimes used, like thyroid supplementation, pramipixole. Generally speaking, I would say nothing major to write home about, but might be considered for certain situations. And then, Jonathan's favorite, there's there's actually some supplements that might be helpful.
Might be helpful.
One of those is N-acetylcysteine. That's probably the one that's been studied most kind of specifically and individually when it comes to bipolar depression. And there's some studies that show that it is separates from placebo. Others that it show that it doesn't completely separate from placebo statistically, but it's trending that direction. And the good news about NAC and acetylcysteine is that it has the antioxidant capabilities. And again, with bipolar, you're often prone to oxidative stress, which can damage the brain. And so the NAC can potentially offset some of that and seems to potentially have some role adjunctively for certain individuals to perhaps help with some of the depressive symptoms.
I'll mention some other ones if you don't mind.
Oh, yeah. How did I know you were going to?
You know me so well. So some other ones might be omega-3s, CoQ10, vitamin D. Interestingly enough, vitamin D supplementation, especially when there's a deficiency, may help both manic episodes, not necessarily acute, manic episode, right? But may help sort of alleviate or mitigate long term, as there may be a correlation, like I said, between the deficiency and the onset of either manic or episodes or depression. Now, these different ones that I just mentioned, the omega-3, the CoQ10, the vitamin D, are they going to help to reduce inflammation and oxidative stress? We talked about lithium having a ability to kind of mitigate those things, be neuroprotective, but some supplements may be able to help with that to an extent as well. B vitamins, particularly when there's a deficiency. Now, oftentimes people are just sort of nonchalantly taking mega doses of B vitamins. We're not necessarily advocating that, but these levels of B vitamins are fairly easy to get tested, and so it may be worthwhile to look into as they're involved in a number of processes, neurological processes, mental health related issues as well. A couple others, ashwagandha, lemon balm, magnesium, melatonin. These may help to reduce stress that is often associated and comorbid with bipolar disorder, may help to improve sleep, may help to improve cognitive functioning. So, once again, if you're in the midst of a manic episode, taking lemon balm isn't going to help you get that sleep, right? This isn't to say, avoid going to the hospital or whatnot, but say you do have mild sleep issues out in between episodes, right? It may be useful as an adjunctive therapy to help regulate maybe some mildly disrupted sleep patterns that you might have and are trying to mitigate with your other sort of lifestyle interventions, right? They also may help to improve cognitive functioning as well. And then the last couple that I'll mention with a major caveat, creatine, L-tyrosine, L-tryptophan. These also, tryptophan has one very related molecule called 5-HTP, which is fairly popular, particularly for those dealing with depression. Now, these may all help to alleviate some depressive symptoms, but really anything that can treat depression, especially in the absence of a mood stabilizer, could theoretically induce mania. And so the big caveat is it's particularly important to be aware of that risk and let your medical provider also be aware if you are considering taking any of those supplements.
Absolutely. Yeah. And again, just for our listeners, I think important to understand that these supplements could potentially help on some levels, but they're very much just adjunctive to the holistic treatment program.
Hence the name supplement, right? They're
Right.
supplemental, and so this is not the end all be all, but something to if you're say you're limited in sort of the changes that you can make with medication or the other things that you've tried, right? They may be something to just kind of round out the edges to maybe give you a little bit of an extra boost, if you will.
Yeah. Yeah. And so, in summary, what I'd say is, to really optimize your life, if you're dealing with bipolar, you really want to explore that holistic approach. You want to, yes, look carefully at what the right medications are, potentially, supplements as appropriate. But then you don't want to ignore psychotherapy, you don't want to ignore exercise, don't want to ignore light interventions. And of course, you want to live a clean life, avoiding addictions and that sort of thing, because that can be a big trigger for episodes. You want to be careful with your ability to manage stress. You want to be eating healthy, drinking enough water. So there's that holistic approach is just key for living the best possible life and having the best outcome. And I will mention one other thing. I think I've seen a lot of people that struggle with bipolar, the spiritual aspect as well, like where they really, as they're connecting spiritually, even if they're struggling, finding meaning, finding hope in finding strength in something greater than themselves can be tremendously helpful and help them even get through those times that are very difficult, realizing they're not alone and that there is better things in store for them.
Absolutely. Great way to end. I thank you so much for this conversation, Dr. Binus. It's always very helpful to hear your insights. And I know that some people will be, some people with the condition or maybe with a family, a member or friend that has this condition will be able to glean something useful and hopefully be able to just be more informed about the potential treatment options and consider whether or not it might be the right fit for them and whether they can talk about it with their own mental health practitioner and see if it could potentially be. So thank you so much. and to our listeners for listening in on this conversation. We know there was a lot of information, and you may need to go back and listen to this one again. I also would be remiss if I didn't mention that most of the things that we talked about, especially regarding lifestyle interventions, we have whole podcasts on those individual topics. So if you want to learn more particular, just because we couldn't go into as much depth about those things, please go through our older podcast and give those a listen. We're sure you'll get some valuable information out of those. So thank you once again for being with us today, and we look forward to our next episode. Have a good day.
Thank you, Jonathan. Thanks for listening. If you enjoyed today's episode, please like and subscribe. Your engagement will help us reach more people who need encouragement. To hear more episodes, learn about our other mental health resources, or support us financially, visit thebrainpeoplepodcast.com.